Thanks, everyone. Good morning. This morning, we're going to be talking about smoking and the kidney. So here's our case for today, and it's a relatively straightforward one. Then I just have to move stuff away from my slides. So this is a 56-year-old non-diabetic man who comes to your clinic for evaluation of chronic kidney disease stage 3. 12 years ago, he was diagnosed with hypertension, and he denies history of CVA, coronary artery disease, and claudication. Currently, he's taking amlodipine and chlorothalidone. He lives with his wife and teenage daughters, and he's actually been smoking since age 19 and is currently smoking half a pack a day, but tells you he's, of course, trying to cut back. And on physical exam, he's overweight. Blood pressure is 148/92. Cardiovascular exam is normal. He does not have bruits, and he has no edema. And data is notable for a creatinine of 1.8 and a protein creatinine ratio of 2,100 milligrams per gram. So here are the questions that this case generated, both for the patient and for me. So first, will quitting smoking actually help slow progression of this man's chronic kidney disease? Is his smoking habit putting his family members at risk for chronic kidney disease? Because of the heavy proteinuria, what specific glomerular pathology would he be at risk for? And finally, I realized I was not aware of the current evidence-based recommendations for smoking cessation, so I wanted to review those for you all as well. Smoking is bad, as we all know. It's the most common cause of preventable death in the United States, and more than $300 billion are spent yearly on smoking-related illnesses. But we are making quite a lot of progress. In 1964, the year I was born, 43% of Americans smoked, and as of 2018, we're down to 14%. But I would say that we can still do better. So when I wanted to answer this man's question of whether smoking would definitely help slow progression, I realized there were a lot of questions on the path to answering that one. My first question was, do we know whether smoking actually causes incident chronic kidney disease independent of other causes? Does smoking independently contribute to progression of chronic kidney disease? How exactly does smoking harm the kidneys? And finally, this gentleman's question of whether stopping would help his kidneys. So let's approach this historically first. In CJASN in 2002, there was a review article on smoking and the kidney. And what we knew back then, first of all, was that smokers actually had a dose-dependent increased albumin excretion rate, even compared to the general population. So even within the normal range of albuminuria, people that smoke actually have a little bit more. In addition, smoking is strongly associated with microalbuminuria in patients with underlying primary hypertension. And we knew by then that in type 1 and type 2 diabetes, smoking was an independent risk factor for progression of microalbuminuria to overt nephropathy, and also for decline in GFR. And finally, of course, we knew that smoking increased the risk for decline in renal allograft function. And if we fast forward about 6 years to CJASN, by then we had large community-based studies of close to 250,000 people from various parts of the world. And these found that smoking actually predicts, or in any case is strongly associated independently with the development of chronic kidney disease and end-stage renal disease. In 2007, our very own DeBoer, Kestenbaum, and Young, along with other authors, looked at the diabetes control and complication trial and found that among 1,000 type 1 diabetics, the hazard ratio for incident microalbuminuria and incident GFR decline was higher among the smokers controlled for other factors. Finally, to summarize a lot of studies looking at this question of whether smoking alone leads to de novo CKD. In Nephrology, Dialysis, and Transplantation a few years ago, a meta-analysis of 15 prospective cohorts controlled for various things was published. Obviously, we can't have a randomized trial of smoking, no smoking, and altogether there were 2.5 million subjects here with 65,000 incident chronic kidney disease patients. And what they did here was they divided them up into former smokers, current smokers, ever smokers, who were a combination of current and former, and never smokers. And the mean follow-up of studies in this meta-analysis was a decade. And this is a forest plot showing the relative risk for new onset chronic kidney disease among smokers, ever smokers. And you can see some of the studies were more convincing than others. All total, they found that compared with never smokers, the relative risk of incident chronic kidney disease was 1.27 if you ever smoked, 1.34 if you were currently smoking, and 1.15 if you were a former smoker. So relatively convincing that smoking is associated with new onset CKD. Although the study didn't really look at this in detail, the risk for new onset CKD seemed to increase based on how much you were smoking. And it also seemed to decrease the distance you were from quitting smoking, although it took quite a few years for your risk to decline. Well, what is smoking doing to the kidneys that's so harmful? So if we start with a cigarette smoker, the path from smoking to progression or to new onset CKD passes through what I would call the usual suspects. On the inner sort of part of this, we have hypoxia, vasoconstriction, hypertension, prothrombosis, oxidative stress, and of course, our very good friend, pro-inflammatory cytokines. And all of these contribute in kind to glomerular hypertension, vascular damage, and increased matrix deposition on the way to what I call the signs of kidney death, which are glomerular sclerosis and interstitial fibrosis and tubular atrophy. I thought a couple of these on the outside were actually provocative and interesting. One is that smoke actually contains heavy metals. So it's probable that lead and other things in smoke also contribute. And then the other interesting thing is that there are actually cells in the kidney that contain receptors for nicotine. There's obviously a huge amount of material looking at the direct harm that smoke does to the kidneys. And so I just pulled a few provocative findings that I thought were particularly interesting to review. And so being a glomerulophile, I found that human mesangial cells actually express receptors for nicotine. And in a mouse model of glomerulonephritis, if you give the mice nicotine, it actually increases production of extracellular matrix. This right here is actually a human glomerulus. It's not a mouse glomerulus. Mouse glomeruli are a lot smaller. And in mouse models of diabetes, there's also increased matrix production among smoking mice. Podocytes express receptors for nicotine as well, and if you grow podocytes in vitro, they actually undergo apoptosis in response to nicotine. From the human body point of view, studies show that cigarette smokers have higher GFRs, and so it's likely that hyperfiltration resulting from smoking may accelerate CKD. And finally, we know that maternal smoking leads to lower birth rate, and lower birth rate is an underlying risk factor, for example, for secondary FSGS, perhaps due to low nephron number. At the nucleic acid level, I wanted to go over one study that I thought was particularly interesting, and this was a study that showed that rodents who were exposed to cigarette smoke develop kidney injury, and that's associated with decreased expression of an epigenetic antifibrotic microRNA. So that's kind of a big sentence. So to break that down, you have decreased expression of something that's antifibrotic. So it's kind of a double negative. So you have increased fibrosis as a result of this. And a microRNA, what a microRNA is, it's a piece of RNA that's not translated into protein. And it's responsible for binding to specific coding sites on mRNA molecules. And most commonly, microRNA function to repress translation or to degrade the mRNA. So microRNA are important for stopping bad things from being made. So if you have an antifibrotic microRNA, that microRNA's responsibility is to prevent the development of fibrosing factors. So if you have less of this, you're going to have more fibrosis. So how exactly did they do this? So they took rats that were exposed to cigarette smoke, about 5 cigarettes daily for a month, and they randomized those to rats that were allowed to breathe clean air. And then half the rats underwent 5 out of 6 nephrectomy, which is a very reliable model for FSGS. in mice, and the other underwent no surgery. And, you know, it was kind of challenging getting the rats to actually smoke. You had to hold the cigarette there, and I'm just kidding. This is actually what they did. So this poor rat, I worked with rats for years, and they really are just the most endearing creatures. So mice are really nasty and they fight all the time with each other, and but rats are usually curled up in the side of the box, and I always used to feel actually somewhat emotional, like pulling them away from each other. But here's a poor Worcester rat living in a cage where smoke is being pumped in. And here's what they found. So on the y-axis here is kidney fibrosis, and these are the 4 groups of rats. And the rats that were subjected to sham surgery but able to still breathe air developed very little fibrosis. The smoking rats developed more, and the rats that had the 5 out of 6 nephrectomy and also smoked developed even more. And here's that helpful microRNA that reduces the formation of fibrotic cytokines. And depending on which group you were lucky enough to be in, if you had air and no surgery, that microRNA level did not drop. But if you had surgery and you were also subjected to smoking, then you had a significant drop in this microRNA. So really suggesting that smoking itself and whatever toxins are in smoking can affect things at the epigenetic or nucleic acid level. So by this point, going back to my questions, I was fairly convinced that smoking could cause incident chronic kidney disease, and also that smoking could harm the kidneys in many ways. On the road to answering this patient's question, the next query was whether smoking contributes independently to progression of chronic kidney disease. And I was surprised to find the answer to this question a little bit debatable. The most compelling data in support of this actually came from the CRIC study. And this was the chronic renal insufficiency study, which looked at 3,000 folks over 4 years. And they had GFRs widely ranging from 20 to 70 mils per minute. And in the CRIC study, they defined renal progression in sort of a conventional way that we do, greater than 50% loss in GFR or new onset dialysis. And they looked at smoking. They adjusted for demographics, clinical variables, medications, proteinuria, GFR, pretty much everything. And they decided to make the smoking people the referent. So the smokers were at 1. And they had an event rate of renal progression events of 88.7 per 1,000 patient years. If you looked at past smoking, you had a significant drop in the renal progression among these patients. And if you looked at the never smokers, you were even very, very much lower. So this was some of the most compelling evidence that being a smoker was bad in terms of progression of CKD. The other study looking at this, and not surprisingly, a lot of the studies looking at smoking actually come out of Korea, and I was shocked when I Googled and found that 40% of Korean men still smoke, only 6.4% of women, but it's still a very big problem in Korea. And this was the Korean cohort study for outcome in patients with CKD, which is titled KNOW-CKD. And they looked at about 2,000 patients over 5 years, also with CKD 1 through 4, also with the traditional renal outcomes of greater than 50% reduction in GFR or new onset dialysis. And the hazard ratio for CKD progression is on the y-axis. And here is actually the smoking load in pack years. And I want you to just focus on this model number 4 because it was adjusted for almost every variable. And you can see pretty clearly that the more you smoke, the more likely you were to have renal progression events independent of other things. But you know, that's not really still the question that I was being asked. So the question I was being asked was, if I stop smoking, will it slow the progression of my chronic kidney disease? So let's go back to sort of basics and look at what the benefits are of smoking cessation and how rapidly they accrue. So incredibly, just 2 months after quitting, signs of circulatory function improves, and lung function can be found to increase by up to 30%. Astoundingly, 1 year after quitting smoking, your risk of heart attack is already down by a half. And 5 years after quitting, your risk of stroke is reduced to that of a non-smoker. But it takes a lot longer, out to a decade, for the risk of lung cancer to be reduced. Well, I was actually pretty surprised to find that there were almost no studies looking at whether smoking cessation would help slow progression. There was a study of about 16 patients in Kidney International that showed that it probably did. And then really the way to get at this question, or the way to get at this answer, was somewhat indirect, but I thought the most compelling evidence came from the recently published KNOW-CKD trial. And so what they looked at was the hazard ratio for CKD progression according to when you quit smoking. They took the never smokers as the reference, and they looked at former smokers and divided them into those that quit in the past 10 years, so quit less than 10 years ago, 10 to 19 years ago, and greater than 2 decades ago. And what they found, sadly, was that if the smokers quit less than 10 years ago, there was still a very significant increase rate for renal progression events compared to never smokers. This was significant. You had to get out to more than 10 years since you quit for that rate of CKD events to actually go down. And obviously by more than 20 years, your rate was still significantly down or similar to that of the reference. And this was actually similar to a couple of other papers that have tried to get at that, all of them really showing that you have to quit for at least 10 years before you really see independently effects on chronic kidney disease. And this prompted this editorial in Hypertension Research, looking at the time course of cigarette smoking, the effect of chronic kidney disease. The effect of cigarette smoking accumulates in proportion to the Brinkman index, and we tend to talk in pack years, which is smoking per day times year. The Brinkman index is actually the number of cigarettes you smoke times the years of smoking. So cigarettes per day times smoking years. And the effect of smoking increases by the Brinkman index. And after smoking cessation, although the effect is clear, it takes a very long time, several decades, similar to that for cancer rather than other vascular disease. And, you know, it's not really clear why this is. Perhaps it's because changes have to happen at the genetic level. But it seems that you really have to quit smoking for a while before you see a significant reduction in your risk of progression. Of course, you know, what I'm not talking about today is all the wonderful things that smoking will do for the rest of your body. But in terms of direct effects on the kidney, you know, I cannot sit and tell someone that if you quit smoking, it's going to help your kidneys in the next year. So at that point, I had answered most of these questions. Does smoking cause incident CKD? Yes. Does smoking harm the kidneys? Many ways. Does it contribute to progression? Yes. Will stopping smoking? Sadly, yes, but it may take many years. So the next question was an easier one. It was whether this man's smoking put his family members at risk for CKD. So what do we know about secondhand smoke? The CDC has lots of reports on secondhand smoke. And just to summarize them here, among adults exposed to secondhand smoke, there's really a very large increased risk for stroke, MI, and even for lung cancer. So, and sadly, we know that children also suffer from secondhand smoke with more asthma, respiratory illness, otitis media, and actually a significant increased risk for sudden infant death syndrome as well. Well, there's only one paper looking at secondhand smoke and chronic kidney disease, and it was actually published just last year in CJASN, also from Korea, from the Korean Genome and Epidemiology Study, which was a 13-year study looking at more than 100,000 Korean subjects. And they all had normal GFR and no proteinuria. So these were healthy from a renal point of view. And they asked the subjects who were non-smokers how many days you've been exposed to secondhand smoke. They divided them up into those that had no secondhand smoke exposure, were exposed less than 3 days per week, and those that had greater than or equal to 3 days per week of smoking. And I thought it would just be easier to use the fun diagram from CJASN. But what they found was looking at never smokers was that the average age was 53, and not surprisingly, 75% were women, because only 6.4% of Korean women smoke and 40% of Korean men. And they divided the study into cross-sectional and longitudinal analysis. Among prevalent CKD patients, among prevalent CKD patients, they found, The data was not that convincing in that the more smoke exposure you had, the risk for CKD did actually not really go up. But in the longitudinal analysis where they followed them for 104 months, they found that with time, the more smoke you were exposed to, the higher your risk for incident chronic kidney disease. So in this sort of preliminary study, there seems to be a relationship between smoke exposure and the development of CKD. So I would say, yes, possibly he's putting his family members at higher risk for CKD. So seeing that he had a lot of proteinuria, that of course piqued my interest. And my question was, are there specific glomerular diseases associated with smoking that he would be at higher risk for? So I want to introduce the term idiopathic nodular glomerular sclerosis. This was first described actually by our own Charlie Alpers and a guy by the name of Biava in 1989. They published the first description of it. And in 2002, Vivek Dagati and friends at Columbia published the largest series of what was then idiopathic nodular glomerular sclerosis, and were the first to link this to smoking. 5 years later, they published another review and decided that they wanted to give this a name, which we now call smoking-associated nodular glomerular sclerosis. Nodular glomerular sclerosis, of course, is just a pathologic pattern under the microscope that we see in many conditions. So we see it in diabetes, in chronic TMAs, dysproteinemias, organized glomerular deposits, and finally, potentially in idiopathic ways. So, and this is what it looks like. It looks a lot like diabetic nephropathy, almost like Kimmel-Steele-Wilson nodules, increased matrix, some degree of mesangial hypercellularity. And Dagati described in her first series 23 people with this condition, and they were all older white guys, and 91% of them were smokers. They had pretty significant CKD, and 22% were nephrotic. And of note, the progression to chronic kidney, the progression to dialysis was very swift. When she looked at the pathologic findings, she found that they were very similar to diabetes, with diffuse and nodular mesangial sclerosis, thickening of the basement membrane, vascular lesions that we see in diabetes. And some of the biopsies had even more diabetes-specific findings, like microaneurysm formation, Bowman's capsule hyalinosis, and of course, the classic afferent and efferent arterial hyalinosis. So nodular glomerular sclerosis, we now know is something that, that we see in smokers, and this man would be at risk for. And Dagati and the Columbia team proposed a very similar sort of diagram to the earlier one we showed on the path from smoking to CKD. I just wanted to point out that smoking also increases advanced glycosylation end products in the kidney, much in the same way that diabetes does. So this is likely one of the mechanisms causing problems in this disease. Well, how about ANCA disease? So we look at various environmental factors in both ANCA disease and anti-GBM disease. And the question is, does cigarette smoking actually increase your risk for ANCA disease? Last year in JAMA Internal Medicine, a case control study was published looking at 473 cases of ANCA-associated disease and matching each patient with 2 controls in the community. The smoking status was extracted from the electronic medical record and also from questionnaires. And most of the patients had MPO, ANCA-associated vasculitis, with the majority suffering from kidney involvement and many with lung and upper respiratory involvement as well. And first what they did was they looked at the number of pack years of smoking and the odds ratio for the development of an ANCA-associated vasculitis. And in their group of patients, those that had very significant greater than 60 pack year history had a very, very increased risk of developing ANCA-associated vasculitis. When they broke that down to the overall figures, never smokers were described as the reference. Former smokers had an increased risk for ANCA-associated vasculitis, and current smokers had a very significant increased risk for ANCA-associated vasculitis. But things sort of fell apart a little bit when they broke it down into PR3 ANCA-associated vasculitis and NPO, because among the PR3 group, this was actually not significant. But among the MPO group, there was a very significant relationship between former smokers having more risk and current smokers having a very increased risk for MPO ANCA vasculitis. So I can't think of a really good mechanism for why MPO, ANCA Associated Vasculitis, would associate with smoking and PR3 not, but it's definitely provocative. So in terms of what specific glomerular diseases he would be at highest risk for, they would be nodular associated glomerulosclerosis and possibly ANCA associated vasculitis. So my last question for today was what exactly are the current evidence-based recommendations to help this patient quit smoking? And this was a survey of just cardiologists, 144 cardiologists, asking them whether they were comfortable with certain activities related to smoking cessation. And about 70% were comfortable referring to a smoking cessation program, 60% discussing pharmacotherapy. And then I just want to point out that only about 56% were comfortable prescribing pharmacotherapy for smoking cessation. And these were, cardiologists. So these people are supposed to be on the front lines for getting people to stop smoking. And I would argue that, given where we are in the vascular tree, we should also be very comfortable with these things. So I just wanted to go over some of the most recent recommendations. This is a long-standing kind of 5 A's recommendation for physicians, that at each visit we should ask about tobacco use. We should advise quitting at every visit. It turns out that if you talk to your patient for less than 5 minutes at each visit, you can actually double the quit rates. You should assist smokers who are ready, and a combination of behavioral therapy and medication works best. And of course, arrange follow-up. If you do nothing and do not offer any treatment, the success of quitting smoking at 1 year is astoundingly low. Whereas with optimal both behavioral and medications, 25 to 35% of patients can quit smoking for at least a 6-month period. I just wanted to go over behavioral versus pharmacotherapy just to give you a sense of what the success rates are like. So group therapy and even telephone counseling can significantly help. Brief clinician counseling is defined as talking to the patient at each visit, motivational counseling to get them to quit. And again, this can be less than 5 minutes at each visit with really pretty significant success rates. So among pharmacotherapy choices, nicotine replacement and Wellbutrin, bupropion have about similar efficacy. And then varenicline really has a very high efficacy compared to other medications. So let's talk about varenicline, or Chantix, because probably some of you have had patients ask for this. Some of you may be comfortable prescribing it, but varenicline is a partial agonist of the alpha-4 beta-2 nicotinic acetylcholine receptor, or the nicotine receptor, which is actually very densely expressed across the mesolimbic system. So it's no surprise that exposure to nicotine is quite addictive. And the mechanism of action for varenicline is it's thought to reduce the rewarding capacity of nicotine. So somewhat like Suboxone, it binds to those receptors and makes them unavailable for smoke to bind. It's been found to be superior to the nicotine patch and bupropion for smoking cessation, although I do want to point out that if you prescribe two nicotine substitutes, that's probably as good as varenicline, but the patient actually has to wear a patch and chew gum, so do 2 separate things. Most convincingly, and I'm not sure everyone is aware, that if you start patients on varenicline, then you improve the rate of smoking cessation, even if the patient tells you they're not ready to quit. So it turns out that if you put people on varenicline, they naturally stop smoking as much and will sometimes quit because they don't get as much rewards. There was initial concern for neuropsychiatric side effects of varenicline, and there was actually a black box warning from the FDA saying not to use it in patients with underlying psychiatric disease, which was difficult because those are the patients that smoke. But then a very large study called the Eagle study in the Lancet kind of blew that theory away, and the FDA removed their black box warning. And finally, this past summer, the ATS, the American Thoracic Society, recommended that varenicline for all smokers, even those who say they're not ready to quit. So we're supposed to put them on varenicline even if they're not ready. And I just want to go over the ATS released guidelines for smoking cessation in July. They start by saying that simply encouraging patients to stop smoking is insufficient. So all patients who use tobacco should be provided with evidence-based treatment, including pharmacotherapy. And we need to put tobacco dependence or smoking directly on our problem list. And they release 7 recommendations in total. I'm just going to read them very quickly and then focus on this one. But for tobacco-dependent adults, we recommend varenicline over a nicotine patch. For tobacco-dependent adults, we recommend varenicline over bupropion. And these were very strong recommendations. This one was conditional, but they actually are now recommending varenicline plus a nicotine patch at the same time. They recommend varenicline over electronic cigarettes. And finally, this one, which I think is important for us in tobacco-dependent adults who are not ready to quit, we still recommend clinicians begin treatment with varenicline rather than waiting. So I don't know how many of you actually prescribe varenicline to patients that are still smoking. I only recently started doing it after preparing for this talk and reading more about the drug. To just bring this home, for tobacco-dependent adults with comorbid psych conditions, we still recommend varenicline. And the last recommendation is just to continue things for greater than 12 weeks rather than 6 to 12 weeks, because that's been shown to be more effective. This just points out, this is a guide to quitting smoking, essentially, and the stars show how well things work. So just counseling and support will get you 2 stars. But varenicline or Chantix and combined, so 2 nicotine replacement therapies have been shown to be pretty equivalent. And you only get up to 4 stars if you combine medication and counseling. So talking to your patients and giving them varenicline is the way to go. So to summarize for the talk, it may take years for this man's risk of CKD progression as a direct result of his smoking to go down. He is possibly putting family members at risk for CKD. His proteinuria may indicate the presence of smoking-associated nodular glomerulosclerosis. He may also be at risk for ANCA Associated Vasculitis. There may be some vascular lesions as well. We did not talk about that he's at increased risk for. And finally, counsel your patient at every visit. Put them on varenicline or consider 2 nicotine replacement methods, keeping in mind that nicotine does accumulate in chronic kidney disease. I wasn't able to find a lot of negative impacts of nicotine in chronic kidney disease, but just to keep that in mind and make sure you have a sense of how much your patients are smoking. I'd like to close with this quote from 2016 in American Journal of Kidney Disease. This was a study just looking at other vascular lesions in smokers who had CKD. And not surprisingly, the study showed that smoking significantly increases the risk for vascular and non-vascular morbidity and for mortality in patients with CKD. For patients with CKD who smoke, the potential benefit from cessation would be substantial and certainly much larger than any drug treatment that is used for cardiovascular or nephroprotection. These benefits have not been properly appreciated by nephrologists, and there is a need for smoking cessation programs to be established as pivotal components of the care of patients with CKD. So I'm just closing with this because I feel like we're very excited in clinic about SGLT2 inhibitors and all these really new cool medications we can use. But the fact of the matter is that if we can get our patients to smoke, that's probably going to do a lot better for them long term than any of these new fancier drugs. So I just want to stress that and hope that everyone can start to work on that more with their patients.